some of the factors that affect something we call MAP, right? Now, one of the questions, right? Josh, this is 2 extra credit questions I want you guys to look up for next week, right? So you can do it, write it. MAP, we're gonna talk about it, but I'm not gonna tell you what it means. That's your job. It's actually easy. Of the 2 questions, this is an easier one. You would think the diastolic one would be easier, because we've all heard of diastolic blood pressure. Most of us have never heard of MAP. But when you look it up, actual MAP is the easier one to answer, right? So in terms of factors that affect MAP, more importantly, I would have you guys look at this. What are the regulation of the heart, right? Intrinsic regulation results from normal functional characteristics, not neural or hormonal regulation. In other words, how does the heart control its contraction by itself? Can it make it more efficient, right? Now, the first thing we're gonna know is this. This guy's name we're gonna hear a lot, Starling, right? He is like the superstar of the cardiovascular world, right? Yeah, I mean, you know, probably want to be more of a superstar. He probably didn't get rich from it though, right? So what happens is this. Starling's law of the heart is the one that we kind of mentioned. The more preload, the more stretch, the greater the efficiency when you contract, right? We kind of talked about it last semester when we talked about skeletal muscles, that there's an optimal length of the muscle, right? The optimal length of the muscle means that every single myosin head has actin it can reach and make contact with. The optimal length also means that there's a lot of space for those actin molecules to move, right? So when that all happens, we're at our optimal length for skeletal muscle. Same thing occurs in the heart, right? What we see is the greater the amount of stretch, right? The greater the amount of stretch of this cardiac muscle, the greater the strength of contraction. What makes this good is usually the increased amount of stretch is caused by increased blood in the ventricles. So the more blood that's found in the ventricles, the more stretch. The more stretch, the greater the force of contraction, the greater the stroke volume. So this law just basically tells us that, and I'll write it down right here, right? This law is basically this, right? Our stroke volume is proportional to our end diastolic volume. Now, what does that mean? End diastolic volume is the amount of blood before you contract the ventricles. Normally it's 130. So at 130, it's not a lot of stretch. It makes sense you're not going to eject as much blood out. When you start working out, you have more blood returning back to the heart, right? You have more what we call venous return. So what happens? We increase our end diastolic volume when that happens. By increasing the end diastolic volume, it leads to increasing our stroke volume. So the more stretch, the more blood we can eject out. That's true if you have a healthy heart, right? If you have a heart that's starting to fail, what happens? You stretch it, you stretch it, you stretch it, and because it's starting to fail, it can't contract efficiently. Right? So in a normal, healthy heart, the greater the stretch, the greater the amount of blood in the ventricles, the greater you can eject out. Just like what we talk about in the skeletal muscles. Now, increased preload is a good sign. Increased afterload is a bad sign, right? Afterload is pressure the contracting ventricles must produce to overcome the pressure in the aorta and therefore move blood into the aorta. That's the amount of blood resting on top of the aorta, right? So I always give this, I'm gonna come back here, right? So let's take a look at this right here. What would happen, so afterload is this dotted red line. What happens if our afterload is higher? Instead of being at 80 millimeters of mercury, it's at 100 millimeters of mercury, right? So we increase the afterload. Well, what happens is this. The left ventricle has to work harder just to open the aortic valve, right? That's what a high afterload means. It means that the left ventricle, instead of opening the aortic valve at 80 millimeters and then starting to eject at 81 and 82, now it has to work to get to 100 millimeters just to open the aortic valve. So it has to increase its contraction a much longer time frame, and it puts a lot more stress on the ventricular muscles. So high afterload is indicative of moving this dotted red line upwards from 80 to, let's say, 100 right here, right? If it's at 100, we start ejecting blood right here then, not way down back here. That means the heart has to work harder just to open the aortic valve, and then has to continue to eject out blood. So it has to work even harder. So a high afterload is actually a bad thing, right? Whereas a high preload means you're stretching it, you can contract better. A high afterload is a bad sign. We want afterload to be low. The lower the afterload, instead of 80, you're at 60. What happens? If you're at 60, right, the heart doesn't have to work as hard to open the aortic valve. You can just start ejecting right away. So there's no pressure, right, gradient that we need to overcome, right? We just eject right away, we hit 61, 62, right? Leaving the heart and the ventricular muscles less stressed. So one of the reasons why we keep lowering that hypertension thing, right? When I was in medical school, I had a blood pressure, when I first started, I had a blood pressure of 130 over 80. Right? Through medical school, it was like 132, 135 over 80. And what happened is, second year, I was borderline hypertension, right? And my blood pressure hadn't changed much, right? By the time I was done, I was like right on that border of being really, hypertensive, right? I was 135, but then lowered the value to 120, right? And my systolic was 135, my diastolic was like 85, right? Before, the diastolic was like 80, and that's supposed to be the normal value. Now it's dropped to like 70. So, yeah, high blood pressure, man. Can't beat it, right? So that can happen. And why we want to have lower blood pressure is it creates less stress on the heart. The problem is this: if your blood pressure is too low, you're also not creating enough pressure to move blood against gravity. So there is something that's too low, in other words, right? My wife has a blood pressure normally, right? I think she just had endoscopy done, right? And she had endoscopy done, and they measured, the doctor was talking to me, right? And she was like, yeah, we just measured your blood pressure at 75 over 50. I'm like, geez, even my lower numbers at 75, right? Much less my higher number. Oh my God, right? But yeah, at that point I was like, yeah, well, it was her heart rate, so we don't see that, some kind of effect, but she's kind of used to having low blood pressure. Women normally have lower blood pressure than men, normally. Unless you're in my family, and every single woman in my family have high blood pressure too. Family history, man. Can't fight those genes. All right. Again, I just want to show this to you guys again. Do not ever put your stethoscope on your sternum, okay? So I'm just gonna, reinforce that. All right? It's not good. You're not gonna hear anything. You're just gonna make it up. Right, so preload is good, afterload is usually bad, and this law of the heart, we're going to see that this Frank Starling actually has a law of the heart, and in chapter 21, he actually has a law about the arteries and blood vessels too, right? So the greater the stretch, the greater the preload, the greater the amount of blood you can eject out, the greater stroke volume, in other words. So preload is proportional to the end diastolic volume, or the amount of blood in the ventricles immediately before systole. The end diastolic volume is determined by the length of ventricular diastole, and the big one right here, and I'm mentioning this word right now, venous return. Right? Venous return is the amount of blood returning from your veins. Right? Most people think, oh yeah, shouldn't it be the same? It's not the same. Right? Again, now I want you guys to understand that when we talked about 201 material, I don't want you to forget about 201 material when we discuss 202 material. Right? In 201, we talked about sympathetic and parasympathetic. Now, obviously, the intricacies, right? We're not going to go through and talk about the different skeletal muscles anymore. But the big topics that we mentioned, we hear again in this chapter, right? So one of those was that when we have sympathetic activity, when you're working out, that's the best example of sympathetic activity. What happens? Well, you start mobilizing blood in your lower limbs. They increase the return from the veins. I'm going to show you in chapter 21, either tonight, probably next week, that the amount of blood that is resting in the lower legs, in the veins of the lower legs, right, at rest, it's crazy how much blood is actually pooled there, right? So when you start to mobilize it by working out, you're actually bringing in a lot of blood back to the heart that wasn't returning there before. So the more venous return, the more blood volume that enters the heart, the greater the stretch, the greater the ejection. Perfect. Right? Afterload. Pressure that must be overcome before a semilunar valve can open. So high afterload is bad. That means that you have a greater pressure to overcome to just open the valve. In congestive heart failure, blood begins to remain in the ventricles, increasing the preload with each contraction. And what happens is that, well, when we start having congestive heart failure, you get more and more preload, but the heart muscles themselves are not contracting efficiently. So it can't eject out blood efficiently, not like in a normal healthy heart. In a normal healthy heart, increased preload, increased stroke volume. But this is not a normal healthy heart. Right? Left ventricular failure results first in pulmonary edema. Right? Why? Because blood always pools from that area that gets to be failed first. So if your left ventricle fails, that blood starts to pool in the left ventricle. Then the left atrium starts to pool with blood because you can't eject it all. And then the pulmonary veins starts to pool with blood. And that's where we get the pulmonary edema. As blood is in the pulmonary veins and it can't move around, it starts to, right, expand the pulmonary veins and fluid starts to leak out. As fluid starts to leak out, we have pulmonary edema and we have inefficient then oxygen exchange. Right ventricular failure, right ventricle fails, and this is usually the most common cause of heart failure is a right ventricular failure. And the most common cause of right ventricular failure is some kind of COPD or pulmonary fibrosis. Nowadays, thank God, most people don't smoke. But if you've ever watched movies of the 70s and the 80s, or if you ever watch, go overseas, go to Europe, go to Asia, right? You will see how many people actually still smoke, right? When you smoke, you increase the probability of pulmonary fibrosis and chronic obstructive pulmonary disease, COPD. In both instances, it increases your pressure in your pulmonary arteries. Your right ventricle then starts to fail. As your right ventricle starts to fail, it's got very little bit of, cardiac muscle. It's easier for it to fail. As the right ventricle fails, blood pools into the right atrium. Then it pools into the inferior vena cava. So you will see people with right ventricular failure where the whole leg and the whole abdomen is severely distended. And the weird thing is this, we give them oxygen, right? And you're wondering, why the heck do we, and we have people that ask, all right, my heart's failing, why are you giving me oxygen, right? Remember what oxygen does in the lungs. Increased oxygen vasodilates. Vasodilating will hopefully decrease the right ventricular pressure, which will hopefully ease that failure, right? Nothing's going to cure it, but this is a non-even medical way to help treat it. Right. Again, we kind of mentioned this regulation of heart. What I want you to know is that in terms of parasympathetic and sympathetic, there's a little bit of difference, right? Obviously, right? Parasympathetic is going to decrease heart rate. Now, The thing about it is this: the parasympathetic stimulation is going to be supplied only by the vagus nerve. It decreases the heart rate. And there's a big one that I'm going to highlight right here. Right? Very little effect on contraction strength. Why? Because it only stimulates the sinoatrial node. It doesn't stimulate the AV node. And the AV node are the ones that directly stimulates the ventricular muscle. In other words, right, parasympathetic only affects heart rate, not strength of contraction, not blood pressure. Now, that's different than sympathetic, right? So in sympathetic stimulation, both the SA node and the AV node have direct activation. So if you stimulate it sympathetically, we can increase heart rate and we can increase force of contraction by activating the AV node. So then we can increase blood pressure and we can increase heart rate. Perfect, right? By the way, this is what we count on when somebody has anaphylactic shock. When somebody has anaphylactic shock, their blood pressure drops, right? Shock is caused by, shock is a drop in blood pressure. So anaphylactic shock, when you eat a peanut and you have a peanut allergy, boom, your blood vessels dilate and your blood pressure goes to zero. We give them epinephrine, which is like sympathetic stimulation. When that happens, I can increase the force of contraction, so then hopefully I can increase the actual blood pressure to resist that shock. People still die even when they are given epinephrine. Keep that in mind, right? So if they take enough of the peanut and they wait too long before they give themselves a shot of epinephrine, right? People still pass away even with epinephrine. Right. Effects of blood pressure, and there's another big one I want you to just understand is, right, the book will talk about baroreceptors monitoring blood pressure. The good thing about it is they monitor sudden changes in blood pressure, but it can only do one thing. So let's go here, right? Remember, if we have an increase in blood pressure, we want to be able to decrease the blood pressure, right? The problem is the actual sympathetic or parasympathetic nervous system that goes to the heart, right? The parasympathetic, it can only do one thing. It only goes to the SA node. So in response to high blood pressure, it actually does one thing, and that is to lower your pulse. That's it. It can't lower your blood pressure. So it's weird, right? You think that, yeah, we can lower our blood pressure because of this response. No, right? When you have high blood pressure, and that's even when you just have a sudden increase, what happens is, right, if it's already high, do we want more sympathetic stimulation? No, they'll increase it more, right? So if your blood pressure is already high, you need to lower it. Homeostasis. The bad thing is, the system that lowers it doesn't go to the ventricular muscles. So we can't lower it by causing those ventricular muscles to relax more. That doesn't happen. So the only thing we can do is to decrease the pulse. And that's why when that doctor was telling me, right, that drop in blood pressure, my wife's low blood pressure, I asked him about the pulse rate. If that's a normal response, right, if it's more than what I expect, so at that point, then I thought that she'd be in stress. If at rest, her heart rate was tachycardic. Then I'm like, maybe you need some vasopressin or something to give it to her, right? That's why, I was asking that. Doctors love me, right? Second guessing everything, right? So, all right. We'll talk more of those receptors later on. Cardiac enzyme. I'm just going to tell you this because this is something good to know when you are in the clinics. Cardiac enzymes that are used to detect MIs. Now, people are becoming, I believe there's actually something I read now that there's a little bit more knowledge. The fact that we don't want to use the word or the words heart attack because we don't really know what it means, right? A heart attack can be sudden arrhythmia and sudden death from it. Or it can be caused by a blood clot. With heart attack, we don't know. When we talk about MI, we're specific in saying that it's a blood clot causing this. Now, cardiac muscles relies on aerobic cellular respiration for ATP production. So cardiac muscles also produce ATP by creatine phosphate, and because of this creatine phosphate, we have a presence of an enzyme called creatine kinase that's found in the cardiac muscle. And because cardiac muscle are striated, it also has troponin. And what we're gonna do is this. When we wanna check if somebody has active MI, we wanna be able to make sure that we can check their diagnostic blood values and an ECG. We want both. That's a gold standard, right? So what happens? We want an enzyme, we want a protein that we can measure by way of a serial blood draws. So we don't just do one blood draw. We do one blood draw every hour and check to see if there's a rise in the values for creatine kinase and troponin, right? You should never see troponin in your bloodstream at all, never, right? The only time you see troponin levels in your bloodstream is if one, you're having an MI, and then your troponin value skyrockets over the course of a few hours, right? Again, we want something that slowly increases, right? Reason why is this? Most people don't go to the ER right away. So if you have a value of a protein that goes up right away and then comes down right away, right? By the time they go to the ER 3-4 hours later, it might have gone down, and now that's gonna be missed. So troponins stay elevated for a long period of time, and it shouldn't be there unless you're having an MI, right? So somebody complaining of chest pain, all right? Complaining of shortness of breath and pressure, and then we check and their CK and their troponin levels are elevated with time. We do an ECG and it shows ST elevations. Wow, that right away we know they're having an MI. At that point, hopefully we can do, some kind of streptokinase, so we can use the body's own clot dissolvers, or if we can stabilize you, do a balloon angioplasty. Right? Perfect.